Welcome to my channel. Today what I want to talk about is being able to identify MIs in a 12-lead EKG. I don't think this is really stressed heavily in nursing school. I don't think it's a big topic on NCLEX, but it is definitely important in the workplace, and I want to dive right into it. I was taught by a really good nurse practitioner in cardiology an awesome trick that I haven't really seen on YouTube or anything. So I really want to get this out there. It helped me a lot in being able to identify an MI. I know that some people do this little trick called I see all leads. If that works for you, awesome. What I do, what I was taught, and what I really liked was an AVL of the 12-lead EKG. This is my poorly drawn 12-lead EKG. I'm a terrible artist. An AVL is lateral. AVL for lateral, and it's kind of lateral to 1 too, right? So 1 in AVL, lateral. 2, 3 in AVF. 2, 3 in AVF is inferior. F for inferior, right? So it's showing us right there. 2, 3 AVF, inferior. And then I think of my boy Sal, right? Then Sal comes to my head, because we're gonna lump these V's into 2s, 2 by 2, like Noah's Ark, right? V1, V2, S septal, V1, V2. V3, V4, A anterior, and then V5, V6 is L lateral. That's the way that I've lumped them up. I really like that technique. It's really helped me a lot. So of course, the most important part of identifying an MI is looking at the J point, right? The ST segment between S and T. Something that I want to stress is that when you are looking at it, you are comparing it to the T to P segment. So what do I mean by that? So this is a normal QRS complex. There's no ST elevation, no ST depression. But here you'll see there is ST depression, right? And compared to what? We don't compare back here to the PR. We don't compare here. We compare to the TP that's behind it. So leading up to the T and the P, you see how depressed this is? And then it comes back up to TP interval. So this is ischemia. Ischemia, injury, infarct will make sense in a little bit. And then here we have real big ST elevation, right? Big ST elevation. So here we are, QRS. We're looking for that J point, and it's so elevated here compared to, and I did exaggerate this stuff a bit. I saw this with a very experienced nurse, right? And she's someone I highly respect, because she said, we need this taken care of right away. So this is severe ST elevation. You see here, the T to the P is so much lower than it, right? And here we have infarct. This is probably an old MI. This is where the Q wave is so pronounced here. You see how dramatic it is, how far it goes down in comparison to these? It's longer than 1 box. If the Q wave is longer than 1 box, it's indicative of an old MI. It's indicative of dead tissue. It's indicative of infarct. And sometimes you will even see it, if they are infarcting right there, you'll see that their Q waves have dramatically increased in size. So the Q wave is going further down, it's widening. So they are infarcting, and sometimes if you reperfuse it soon enough, you'll see their Q waves decrease in size. So with chest pain, something I wanted to talk about. So with MIs, with this ischemia, infarct, what's really happening anatomically? What's happening inside of our body? So I drew these little arteries here. Again, not a great artist, but you'll see here this artery, the first artery here, this is pain that's caused by exercise. They're getting ischemic here. Not a lot of blood is passing through, but they feel chest pain when they're exercising, when they're eating a lot, or when there's extreme temperatures, when they're emotional, right? Emotions, exercise, and eating, they start to feel chest pain. But at rest, it goes away. Why? Because it's not completely occluded here. That little black plaque is not completely occluding the artery. Then you'll see minimal activity. This little black plaque is really starting to occlude the artery. There's not much space for blood to go through, so minimal activity. Just walking, they feel chest pain. Light activity, they feel chest pain. And here we're in big trouble, right? At rest, this person has chest pain. This black plaque completely occluding lumen of the artery, and at rest they're feeling pain. Nothing stops this pain. Mona, our morphine, our nitro, it does not stop this pain. Now, while we're talking about morphine and nitro, something that I want to stress, and this is on exams. This may be on the NCLEX. I know this is like on CCRN. This is on other exams. This is something that experienced nurses will ask you sometimes. So you do want to know this. Inferior MIs do not get vasodilators. We do not give nitroglycerin or morphine to people who are having inferior MIs because they're having an RV infarct. We do not want to vasodilate them because they are preload dependent. I know I'm throwing a lot of information at you, but what I want you to remember is inferior MIs, F morphine, give fluids. A lot of F's in that, right? So when you see 2, 3, and AVF with elevation, you say F inferior MI, F morphine, F nitro, give fluids. That's a nice way to remember that. Door to balloon pump time is currently 90 minutes. I think it's being pushed so that it can be 60 minutes. Reperfusion, getting them into the cath lab and getting them reperfused, getting a stent there, that is the key. That is the treatment. A lot of times people aren't really even having true MIs anymore because they're not infarcting. It's a myocardial infarction. Really, they a lot of times just have injury or they just have ischemia. We reperfuse them so quickly that they don't infarct, they don't get dead tissue anymore because the medical community has just advanced that much. So we see ST segment depression, ST segment elevation, we're quick on it. Johnny on the spot, right? We get it reperfused so that they don't get dead tissue. They don't get these big ugly Q waves showing that they really infarcted, that they now have dead tissue that electricity isn't even going through. It's like a black hole. So I want to show one more paper, the one that I want to stress because I do feel it's important for identifying and knowing. We're looking at ST elevation or depression at the J point, and it needs to be in 2 contiguous leads. So what does that mean? It's just a big word for saying it needs to be in 2 leads of the same place, same areas that we're looking at. But we already know these leads, right? Because we say 1 and AVL is a lateral wall MI. 2, 3, and AVF is an inferior wall MI. V1, V2, now we're going to Sal, right? Septal. V3, V4, anterior. V5, V6 is lateral. I hope this helps out. I hope this helps you out. Best of luck in the workplace, and hope you all have a great day. Bye.